The reality is, I grew up as a cowboy, and was totally bored in the middle of nowhere. I mean, and that's literally where I grew up, in the middle of nowhere. There was a local surgeon who started with, I'm sorry, let me retake. There was a local surgeon that had a nurse anesthetist that was with him, and he took me on a few rides. In those days, you didn't need HIPAA or any of those kind of things, and I got to watch him. And I thought actually that being a nurse anesthetist was probably not a bad deal to do. So I started a program that had a dual nursing and anesthesia track. You did all your coursework simultaneously, and then once you were done, you did your anesthesia clinical. The reality was, in the second half of my junior year, I did psych and met a young man who had schizophrenia. I'd never encountered anybody with any kind of real serious mental illness, and was absolutely fascinated. What I was fascinated with was the fact that while he had word salad, he couldn't put two sentences together. He also could sit down and play Bach on his guitar in classical style, and I was just amazed at the incongruency. Went back, dropped the anesthesia courses, signed up for all the psych courses I could, and never looked back. The program in psych mental health nursing here is important, not just for nursing, but really for the region and the country. Psych mental health issues have long been ignored, and over the course of the history of this nation, we're now paying the price for it. With Dorothea Dix, we initially took everybody off the streets and put them in institutions. And then at some point in time, we decided that the institutions were both ineffective treatment and too costly. In the 1960s, we then decided we were going to take them all out of the institutions, put them in the community, which was a good idea, except that the money didn't follow. The country decided to save the funds for that. And so we now have, across the country, a huge deficit of mental health services. The belief system that it is somehow related to a willfulness or an emotional state on these people's part is largely what drives much of it. Unfortunately, the research is showing that that's not true. Now, there is a question, I will grant you, of how much willfulness and psychological interventions can change those states. But as long as we continue to believe that it's behavioral willfulness, and that's represented by the change from psychiatric mental health care to behavioral health care, as long as we continue to believe that it's a behavioral issue and people having control over it, we're going to continue to have problems. But the program here really addresses both sides, the behavioral components that people can address, as well as where those services need to address. I'll be the first person to tell you that I think as a specialty, psychiatric mental health care, have really failed this country. We failed this country because we sat back and decided that all we would do with the budget cutbacks is catch those cases that are most disastrous, where people are the most ill. And that's really reflected in our current diagnostic standards manual, in that we only have diagnoses for things once they hit the worst states possible. We have absolutely no emphasis on prevention, early intervention, and growth. That's where our program becomes really important, in that the faculty here and I have decided that we will make two major interventions. One is that we're going to switch a little of the emphasis and include courses on early intervention, prevention, and detection, as well as caring for those that are most seriously ill. And simultaneously, we're going to change the location. We've changed the location to focus on what is called integrated behavioral health care. And so we're training people in a variety of different settings and a variety of different models to try and help expand the services that we give for these people so that they don't have to get to the point of where they're just homeless, which is one of our biggest problems in this country right now. And so the faculty and I have really decided that that's where our emphasis is, as well as the expansion of some of those skill sets into people that have not traditionally been certified as specialists. So, an example, our peds nurse practitioners, our primary care people, really need a set of simple skills that we teach in some of our courses that really helps them deal with the early interventions and detection of those cases. So the program here is really much more expansive than just the specialty of psych mental health. And it's much more important in terms of the health care of this state and this region, simply because we look far beyond just catching those cases at their worst state. I came to CU really to expand what I was doing previously. At the University of Nebraska Medical Center, I was one of the founders of the Behavioral Health Education Center for the state of Nebraska, which is a legislatively funded thing that worked on integrated behavioral health care and focused on those things. I had grants there, just as I've got here. But the opportunity here is truly because of some very kind, socially conscious soul that donated a very large amount of money to make the endowment. The endowment and the goals that the dean had for the department really allowed me to expand the scope and expand all of the places that we could do that work in terms of integrated behavioral health care as well as continued care of the people with serious mental illness. So it was really an opportunity, and an opportunity I couldn't turn down. One of the things that the psych program here does, and most certainly the psych mental health faculty that we've managed to gather together, literally from across the country, is that we don't represent what has traditionally been the structure and face of the programs, which is largely non-diverse, kind of homogeneous perspectives. The Psych NP program here has the highest level of diversity that meets or beats the state demographics every single year. That work over the last 2 or 3 years has really begun to pay off for us, particularly with the advancement of our fellowship program. The endowment has a series of 5 fellowships that are advanced practice fellowships and one advanced research fellowship. And in looking at including people who are really diverse in that really helps us because it relieves a lot of the financial burdens that they have. Additionally, we've continued to expand our fellowship and diversity by tapping into the SAMHSA minority health fellowships. CU currently has 2 of the 12 minority health fellows, one of whom is the young lady I mentioned the other day, who's just entered the DNP program and will be the first Hispanic psych DNP in the state of Colorado. We recognize and really value that diversity, knowing quite well that there are things that are in culture that we, even with the best of intentions, don't get the subtleties of, which become critically important when you're doing psych mental health care. And so these people are really kind of our vanguard, our cutting edge of people. We're very proud of them. They're remarkable human beings, and they will do great things for the state of Colorado and this country. The psych mental health program here at CU is not restricted just to the nurse practitioners. The psych mental health program here truly goes from the undergraduate through the graduate to the DNP and inclusive of the PhD programs. one of the analyses that the endowment has allowed me to do is to recognize both pipeline in terms of workforce as well as areas of deficits. And the Psych NP program here really tries, or the Psych Mental Health program here, really tries to address all of those issues. So we have faculty looking at some of the educational deficits in terms of lack of clinical training sites with mental health simulations in the undergraduate program. Within the NP program, I've told you about the expansion into the integrated behavioral health care and alternate settings. Within the DNP program, we're looking at truly the premier advanced practice kind of leaders who have a good understanding not only of economics, but some of the high-level kind of quality improvement research and stuff that needs to be done within the field. And then at the doctoral level, at the PhD level, we have 4 or 5 very bright young people who are looking quite closely at areas of their interest, some of which are really on the cutting edge of some of these things, such as the biophysical changes associated with triggers to commit suicide and the relationship between different physiological states and early onset vascular dementia. So to do that, we've really been very fortunate in that we've gathered from across the country a collection of 6 faculty who are some of the brightest, youngest people I've ever been able to associate with, and most certainly it's been a great pleasure. But that gives us both a number of advanced practice nurses that's literally higher than almost anywhere except Vanderbilt, who've been around a lot longer than the 5 years we've been around, and really start on some new kind of paths and new ways of looking at things. Interestingly enough, when you look at this faculty, 3 of them were not nurses to begin with. 3 of them were therapists before they became nurse practitioners and advanced practice nurses, which gives us a whole new perspective in a lot of the course content and curricular approaches. Now, they are advanced practice nurses now, all 6 of us are, but it really makes for a very powerful faculty, and I'm very pleased to be associated with them.